All right. So, as I always like to start off, you guys, I always say these are very raw. I'm just kind of doing these on the fly. So you kind of get what you get, jokingly, but more so this kind of again, this is not me teaching you your whole career in an hour or so, but to really broaden where you need to study, maybe some things to deep dive because I can't teach you every little aspect, and everyone's learning style is very different. So I like to just do these just so you guys A, have something to access, and B, something that's easy to stop and start and kind of pick up where you want to kind of leave off on some certain areas. And again, kind of do a little research. For me, I felt like when I kind of started digging and reading articles and watching other webinars, some stuff really sank in. But again, everyone learns their own, and these are very raw. I don't like doing multiple takes because usually I run into me just like raw and lecture running over words, and or you hear Duke and Bruno in the background, and I just don't like to always start over. So this is just me in my, true Kelsey's corner, as in my house, in my office, and just kind of shedding some wisdom. So with that, there's a really big topic on the VTME, and that's going to be the nursing section. So that's about 22%, I believe, of your VTME. So that's a big kahuna right there. So this is where you really got to kind of start trying to categorize and put things into certain areas to help you kind of what helps information stick. So I figured because there's going to probably be a lot of questions on certain areas, I'm just going to do a very broad today, as in this is just me laying the groundwork. And then I do intend to do part two and potentially part three by the end of the week, where I will go into a little more deep dive, okay? Because there are some things that hey, I'm going to touch base on here and be like, I don't remember learning about metabolic acidosis. I don't remember learning blood pH and, fluids and math and all that jazz. So, again, this is something to kind of give you a little preface as a whole, but then there's going to be some things I can kind of riff and go and branch off more specifically, like when we talk about cardiac stuff, cardiac emergencies, respiratory emergencies more specifically. How do we correct that? Disease processes is going to be kind of a big direction too, because like once I get this information of my patient is not doing well, how do I kind of go about that with figuring out the disease and treatment and potential side effects and XYZ. So not to kind of shock your brain right now, but this particular topic is gonna be like a three-part, hopefully not four-part. I'd like to maybe kind of change it up a little bit, but a three-part I think is fair because there's definitely going to be a lot parts to it. Okay, so this is kind of like nursing and emergency all in one. So this is where there really isn't specific direction on some things, but a lot of things when we talk about like nursing as a whole, it can be just for at clinic general purposes stabilization, but it can kind of escalate from there into a true emergency. And so some of these things we can catch in a generalized nursing assessment, but if they're not caught, this is kind of the extreme we can run into. So this is where we have to know, hey, if I'm seeing XYZ, these are some major potential risks that I can be dealing with my patient. So that's why it's like I kind of categorize this as like, hey, this is nursing, but also kind of emergency as well. And then we can kind of go more into depth on some of these. So again, very surface level. So when it comes to assessment as a whole, we got to think about the ABCD method, okay, and what that entails. So a lot of times, a lot of this stuff isn't just relating to emergency as its own. We can be doing this type of function and talking about triaging, even in a general practice, non-emergency situation. And that's something when we talk about where does the root content of things come from. So, I'm very big on words, why, where they come from, terminology, and kind of going back to the who, what, why. So triage is meaning to sort, right? So this is where we have to decide what patient is seen first. What are we looking at ideally to kind of rule things out? Again, when I'm doing my assessment and my going through my body systems with my patient, I don't always have to be an emergency mode, okay? But there are key things that stick out for system. So when we talk about the ABCD survey, this is basically that systemic approach where I'm able to see what's going to be more critical for my patient, okay? So we talk about what does it stand for? Well, that's going to be airway, breathing, circulation, and disability. But this is where we want to make sure all vitals are pretty much evaluated to determine, hey, who's going to be seen first, especially in an ER setting. So there's a lot of triaging that occurs, and this is where you have to communicate to clients, hey, it's a good thing I'm not rushing you to the back right away, right? You know, if I'm not worried, you're not worried right now. However, on the flip side, this is even on the GP setting. I might have my first clinic was a 15 doctor walk-in only practice, guys. Let me tell you, like trying to kind of triage that in a sense. And so we really had to categorize it by sick pet and healthy pet. And even the healthy pets, I still had to kind of determine like, hey, what's the route of my, intake? Okay, not only what are they here for? I mean, I had a dog come in for a just vaccine appointment, and you guys, the temperature on this thing was literally 96. It was not doing good. It was paler than pale. And when I went to take its temperature, I realized, oh dang, this thing's a pio. Because I was like, hey, are we sure Fluffy is intact? Sure, absolutely. And so when I go to get the doctor and he's like, why, what's going on? I was like, that dog is not getting the rabies today because I think you're going to have to spay it. And so this is where you still are doing that prioritization, okay? So we talk about airway. So airway, A, number one, this is very, very crucial. Okay. We got to have some form of patency. And so this is where we can run into some things. So this is where we can see any type of obstruction. Okay. Dog with a stick down its throat. Masses can be a big deal as well. We also can run into a lot of things of where we can see patients being distressed. So a sign or a sound that relates to this, we call it stridor. And so that's where we'll kind of hear different types of wheezings on inhalation or exhalation, depending on the sound. But essentially, no air, no basically survival of life, if you will, right? Because we talk about how what do red blood cells do? What is their main function of life? So keep that in mind, right? They take oxygen to all surviving tissues. So if I have a compromised airway, we's in trouble. So the other thing too is not only about the airway, but I got to talk about the breathing evaluation. Okay. This is like, what's the respiratory rate like? What's the quality of those breaths? Are we seeing things like tachypnea? Remember, not tachypnea, tachypnea or apnea. We can even be talking about different types of efforts, right? I can have short, um, rapid breaths, uneven breaths. I can start to see some misalignment with the efforts changing and sounds. So it's like I have to be very mindful of like what is that breathing rate like, okay? And what does that potentially make my brain go to when I think about the airway? Again, the other thing too is circulation monitoring. So this is where I really want to look at pulse quality, capillary refill time, blood pressure. These are kind of starting points to help identify types of shock or potential cardiovascular distress, toxicity. So circulation is a really, really big one too when we talk about that EBCD method. And so this is where too, like a very, very thorough history is going to help this triage, no matter what approach we're taking, be really important because when I start to be like, hey, Fluffy's here for difficulty breathing, and if I know that this patient potentially has cardiac disease or respiratory disease, I can then kind of further help determine what's kind of, going down that checklist. The last part of that sequence, our disability assessment, so being argumentative, so cognitive function. So this is basically helping me determine what's the neurological state of this patient. So this is where level of consciousness, responsiveness, this can tell me a couple of things. Like, again, is this dog a foreign body problem? Did it eat something it shouldn't that's causing some neurological damage? A big one here that I've seen is people don't admit that their dog got into pot. Like, listen, not calling the cops, but it does inhibit cognitive function on our patients. And then we just get to prolonged treatment because we got to play this game of like, listen, I know he ate your bag of goodies, but I need to know what kind of goodies those are, okay? But on the flip side, other neurological things. So when we talk about neurological um like compromisation. This could be anything like diseases. So of course, rabies being the number one, like when people are like, telling me it's a rabid animal, that's that correlation of neurological issues. But also on the flip side, with neurological, you guys have probably come across dogs that are down in the hind end. Okay. So those are potentially like our IVDD dogs. So not always just a little wiener dog or Frenchie. I've seen an IVD dog and a golden. And knowing what that compromises, you're like, wait a minute, like he's cognitive, but how does it just fall under like the neurological? Well, it's fine, right? So this is where I have to really start to do that mind map. Okay, so here's effort, here's letter A going down to subsection B, C, and then C1, 2, 3, and just kind of going through those motions and filling in those gaps the best we can. So now that we kind of established what's triage, right? And it's basically how do we sort patients? And it's not to always be on an emergency ability either, but some key organ things. So I will preface that this is definitely more of a VT&E approach on if you had to triage a patient and you had one from each category, which one are you prioritizing? Okay, so think about that and you gotta let me know. Well, I know this is recorded, but I'm not telling you. You got to deduce that from what I teach you and in your own research on, do I pick an animal in this category of organ system distress or this one? Okay. So the first, big one we talk a lot about is going to be cardiovascular system. So not me just being like, it's my favorite system because I took I was in cardio. It's a big part, right? It's really crucial when we talk about not only oxygenation flow, but also like weight of life. But the big thing is we do know it aids in some form of transporting that. Also, we did note, hey, oxygen is transferred across the body through um, red blood cells, and so tissues need oxygen to survive. The heart also does help, with some waste product removal there with the system, right? It's a circulatory system. There's two parts of it and they go hand in hand. I can't have one without the other. And so when I talk about, cardiovascular system, I really need to not only assess the heart rate. Okay, I need to really listen to what does that sound like. Okay, I need to hook this bad boy up to an ECG. I need to see what are those waves look like. I also need to get an idea of what that blood pressure looks like. Okay, because this is not only just giving me an insight to the cardiovascular system, but like we talked about, that the blood has to support the entire body, and once you start getting comfortable with identifying, what symptoms can present with what systems and potential diseases, my big thing is if I come across a patient who potentially is dealing with a cardiovascular emergency, signalement, okay? Who are our poster children for some form of heart disease, right? So we do see a lot, of course, King Charles Cavaliers who go through that. There are different types of when we talk about cardiovascular issues. Just because there might not be a structural relation to that dog. I need to know some breed, predisposition. So I harp on this with Bruno being a Doberman, DCM. Some of you guys might have been exposed to boxer disease. We call that ARVC. That's not a structural heart problem, but if I have a boxer coming in for passing out and weakness, my brain is going to be like, we got to get an ECG on this guy and see what's going on. On the flip side, I could have a 19-year-old cat who's going bonkers, um, and might have an uncontrolled thyroid problem that's giving me a ridiculous blood pressure, which I'll go into this more detail, but if you paid attention in my class, the kidneys are a big part of the blood pressure. So blood pressure is not just heart related. But my big point here, my little soapbox, if you will, is I can't just listen to if this is tachycardia or bradycardia. There's so much more involved in the cardiovascular system. So, an emergency situation, I really got to make sure that this system is not compromised because, again, it's that working wheel of providing a lot to other systems. So, cardiovascular system is best friends with the respiratory system. Always has and always will be. So, 9 times out of 10, if it's here for a cardiovascular problem, it also has some respiratory problems. On that note, if it's here for some respiratory problems, I'd say probably about 65% of the time it also has a cardiac situation. Okay. But when we talk about respiratory, you guys know there is gas exchanges happening, which that occurs in the alveoli. Okay. Sound a little familiar? When we talk about where does the oxygen molecule go when the patient inhales, right? Goes in the nose, down into the trachea, down the bifurcation, into the respectable different lung lobes. And then we have, the alveoli and the capillaries and the whole, kit camp caboodle. So there's gas exchanges. And so if we're having problems here, we can lead into a lot of other things. So we can have hypoxia or hypercapnia. So this one, remember I always joke your left and your right vet med are not the same. So if I have a patient who is hypoventilating, okay, low breaths, okay, think about it. So we have hypoventilating, they're going to be hypercarbia. Okay, if they are hyperventilating, they're going to be hypocarbia. It's opposite. Think about it. If I'm taking short, um, rapid breaths there, we talk about hitting that EtCO2 line and getting that full flux of seeing those waves. So if I see my patients breathing being short little spikies on that Capnell graph, they're not hitting that baseline. Okay. So we're having some issues with EtCO2 problems. So they're not compensating correctly. And so this is where we can run into some metabolic structures when we talk about acidotic or alkalosis. Okay. And on the flip side, if I have a patient who's so deep and they are hypoventilating, their waves are beyond that baseline. And it's like, whoa, we also run into a point that patients can rebreathe that. Okay. So we have to be very mindful. We don't want them rebreathing on those anesthetic gases when when we watch that EtCO2. This would be really helpful if I had a visual. Sorry, kind of using my brain on this one. The other thing too is we can run into some dogs who potentially, if it's hit by car dog, collapsed lung. We can also be seeing some other respiratory problems with fluid on the lungs. Okay, their respiratory effort is going to tell me a lot. Okay, the body always wants to hit homeostasis, meaning its base mechanisms, its base normal. So this is too, again, a crucial history on a patient, um, knowing about if they do have a history of some type of cardiac issue, what's their sleeping breathing rate? What are their breathing efforts? If this is a cat, maybe this cat has asthma. Here in Arizona, we do battle the whole valley fever situation. So, that's always at play. Cancer, right? We can be dealing with that as well, causing some respiratory dysfunction. Okay. We can even run into some respiratory problems right under anesthesia. So we have to really keep in mind what's involved in the respiratory system, and if it's compromised, what can we see happen? So again, with the neurological system, we did briefly talk about, cognitive health. So this is where we can see not only changes in consciousness, but we can kind of identify if there's any lesions going on in the brain, down the spinal cord. We can see things from head trauma. This is going to determine, hey, what kind of fluid should I put this dog on? Does this patient have a history of seizures? Um, and so on and so forth. And then also we can see some not just like head tremors that's like, oh, this dog is off neurologically. Like we can look at patients' eyeballs and see potential occurrences within the neurological system there. And so the neurological system is probably a bit difficult in my opinion, because then it's like the biggest thing is when we pass this off to neuro, they got to figure out where the lesion is in the brain, if this can be fixed and what that looks like. And then, of course, always a factor that will never escape is valley fever. So. And then the renal system, so big component here that I feel gets forgotten, because if a patient cannot urinate, they are going to die. So you again know that male black, not particularly black kitties, sorry, male cats they go through blocking episodes, stress and things like that. We also can run into dogs that with some issues in their production of urine, if they're having, again, a history of being on diabetes or also cushion weight, we have to manage that. And if they're not producing urine, that's a big problem there. We also run into some breeds that has specifics that can cause more uh like when we deal with urinary crystals and stones and XYZ, and of course cancer as well. We have to keep that in mind. And also, how are the kidneys functioning? Okay. Because if just because the animal isn't necessarily urinating doesn't necessarily mean like that is a key sign of problems with the renal system. There could be some other things going on that also are setting the ability for that um, key part component when we talk about what does it do with elimination, right? Also, these guys take a big hit with drugs. So again, if I have a patient in a GP or ER setting that is somehow compromised with its kidneys, that's going to limit my options. Okay. So, got ahead of myself. Sebastian always laughs. He says, "Is this what class is like?" I'm like, actually, this is pretty tamed. We get a lot more off topic because we all just banter. Or you guys call me out on my misspellings. But anyway, importance of history. Okay. This is key component in emergency or not. Okay. What's this dog? Does this dog, like to eat things it shouldn't? And some people have foreign body children, and that's just inevitable. What are they exposed to? What's their life like? Because if this is a farm dog and I just put rat bait out, what kind of rat bait? Also, have there been any changes in the house, changes in behavior? Like you got to be really thorough. Any, medications they're on, how much? When's the last time they got that checked? And this is where you kind of take your knowledge of how you understand those medications, but also how's that patient presenting, XYZ, all of that. They're, they're drinking a lot of water, and it's like, okay, do you feel what they're intaking is equaling what they're excreting? So you really got to be strong in understanding the importance of history, because also, if I see a Doberman walk up and it's here for respiratory distress, my first thing is DCM. Okay. And so knowing things like that is going to be a key component. If I have a potential Yorkie who is struggling to urinate, my first thought is I'm gonna have to do a CT to do a shunt hunt. So history and signalement is very, very key to determine how do we go from here. Okay. So we really got to be confident how we kind of jump into things on that. So this is where we want to make sure, hey, you got to get your flow, okay? Even not, I know some of this might come off in more ER sense, but even in your GP sense, okay? You got to have a good flow, the whole nose to tail, intake's got to be quick, room's got to be quick. You got to kind of act on like what's happening, okay? You got to rely on the data, you got to rely on your gut on some things. So, all right, so that's a little preface into something. So now we're going to go back to the beginning a little bit. So again, like I said, this is going to be pretty much a three-part series. I'll go more in depth on some of these systems like I did in small animal nursing and then some. But again, normal airway sounds. So we want to make sure we have access to an airway, okay? So sometimes in an emergency situation, we got to do tracheotomy and just put a hole right in the middle there so we have access. So again, knowing your breeds and some certain like deficits, right? Soft palates makes it a B-arch to intubate if I have a compromised pet and depending on what else is going on. And so we want to make sure when it comes to the respiratory system, we hear normal airway sounds. Okay, we want to make sure free of obstruction, wheezing, raspy sounds. This is going to be a key component to help kind of determine, imaging and diagnostics. So certain sounds can attribute to upper and lower airway system. So, again, make sure you guys know your anatomy because if you're given a question that's going to make you kind of break down every answer, you're going to be able to, categorize what you know into those areas. And again, you don't always have to know the whole context of the question, but if you at least know some basis of some topics, it will set you up more likely for success. So we talk about with upper airway noises, we do hear something called stridor. So this is where we'll see a lot more like LARPAR or laryngeal paralysis. In small medicine, they call it laryngeal obstruction. It's the same thing as horses with roars, so I just call it LARPAR. So that's where we have that paralysis, okay? And so that's a big component we do see there. And then on the flip side, from stridor, we have something called stertor, which is more of a snoring sound. And so this is where we actually see more of an obstruction in the nasopharynx area or part of the throat specifically, not relating to like the larynx and when we talk about like the epiglottis and things like that. So keep that in mind, stridor versus stertor. Okay. And we talk about like the upper respiratory tract, okay, and what are some things we can run into there. So when I talk about watching for normals and things like that, you gotta talk about the abnormal. So when we talk about stridor, so we see a lot of distress on inspiration. Okay, so there's some form of an airway obstruction. So this is where you have to hurry and make sure we get access to provide oxygen therapy in the best way we can. So big examples. So masses can be blocking parts of the throat, and that's no one's fault not knowing that. It's not like I can easily be like, say, ah, now I do wrestle my dogs to, check, but at the end of the day, sometimes things do pop up truly overnight. But we do relate stridor to brachycephalic syndrome, i.e., soft palate. We also can actually categorize tracheal collapse here with the stridor due to where we see those difficulties of this patient. So distress on inspiration. Okay. And so when we talk about where can these obstructions occur, so it's all going to be that upper part, so the pharynx, larynx, trachea area. We can see some in the lower airway, so that bronchi, that's kind of inducing the parts of labor breathing and potential of that noisiness. Okay. And so if we don't find the result to the stridor or figure out what's causing the stridor, patients will become cyanotic and pass out. Okay, we're not getting there. So the brain goes, you know what? Hard reset on that. And of course, when they're stressed out, like, do they breathe any better when they're stressed? No. So that's why the brain takes over. So again, listen, your book is going to have different numbers than what I was kind of referencing. And so take it with a grain of salt of some average. So, whatever you've already documented in your studies, stick to it. This is just something from the archives of mine. So it's like, okay, for dog, when we talk about respiratory, cats anywhere between 24 and 42, dogs 10 to 30 breaths per minute. However, understanding, hey, younger, smaller animals might have increased values, and larger dogs might have a smaller value, okay? Of course, we can see some deviations in these rates, which can indicate a lot of things. So, heart disease of some sort, okay? I'm just bulking this in one category because there are different types of heart disease, and they're not all related to congestive heart failure. Valley fever, of course, because it doesn't play by the rules, cancer, plus or minus any other systemic diseases, or even metabolic at that. So like our cats, they do get asthma, any type of viral infection. So we can see some changes there. So the thing is, when animals already have predisposition of things, in theory, their normals can change. So, but when I'm talking textbook clear of everything, my references is 10 to 30 breaths per minute for dogs and 24 to 42 for cats. Again, stick to what you've kind of referenced or made a card out of, but know those and kind of that way you can again eliminate any abnormals. So let's talk about those. So the abnormals, terminology, okay, boards will make sure you know what you're talking about. So when we talk about what's apnea, so this is indicating no respiration presence, and then we also have tachypnea. This is increased respiratory rate. Then we have something called agonal. So these breaths are the last gas essentially before patients respiratory failure or pass away. Some big things that like to stick out. So, I always call this just Chine Stokes, but it might be like the Shy Stokes or not necessarily Cheyenne Stokes. But this is what we talk about when The breathing involves cycles of rapid breaths followed by a period of apnea. So there's a lot of basically discombobulation when we talk about this one. The other thing too is we have something called orthopenia. Okay, so you're like ortho bone, but I don't follow. So this is just essentially stating that patients are going to adjust their body in whatever position necessary to breathe. So this is where we can see a lot of patients who might be in a Snyder, where they are sitting sternly and their neck is extended to all heart's content, and they're nearly like gasping for air. You might even see patients who are up, down, in the praying stance as well, trying to further assist some form of airway ability while they're trying to make sure they get air. So again, surface level studying. So there's definitely a couple more to this list. So, add to it. But again, we'll talk more about the systems in depth here. So, the other thing too, when we talk about knowing our systems and our norms, okay? So, mucous membranes, again, this is not just oxygen relation, okay? This is perfusion, telling me about blood flow to the heart, okay? Because oxygen does need to carry, oxygen is carried by the red blood cells. So, that's where I talk about perfusion. So, mucous membranes can give us a sign of a lot of things. So again, pink tissue, a lot of cells activated essentially there. When we talk about poor perfusion, typically grayish. So this means this patient potentially could be in shock. And so now the body is prioritizing who gets blood before each individual system starts to shut down. We also have additional more pale light gums, so this can give me an idea of anemia potentially. So patients bleeding out somewhere. Okay. So we have to keep that in mind. So a lot of people, when they think mucous membranes, they're relating it more to lung capacity. So again, it's more of like in relation to the circulatory system and the function of red blood cells. When we see brick red, so this is a sign of septic shock. So this can be anything from widespread infection and potential organ failure. So we really got to get into figuring these things out. Of course, yellow, so we call it icterus, okay, or they're icteric, though this is in direct relation to hepatic dysfunction, okay. So this is where we'll see that jaundice appearance, and so this is definitely more so liver disease or some additional blood type disease. And of course, blue, they're hypoxic, so, insufficient oxygen altogether. So this is extreme attention. Brown, so this is the methylglobinemia. So this is basically acetaminophen toxicity. So this is a true emergency there. I would definitely know this one. This is definitely a known to be VTE question. Not necessarily word for word, but you gotta know stuff. Okay, speaking of, so kappa refill, so that's our CRT. What's normal, right? 1 to 2. So this is telling me, hey, perfusion status of this patient's pretty darn good. That means blood is flowing. When I see some prolonged, I definitely have some poor perfusion. It definitely might not be related quite to shock. There could be something else going on that doesn't necessarily tell me it's shock related, but it's the body telling me something, yo, we ain't in the right levels. When we talk about rapid, okay, less than 1, this is actually what we call hyperdynamic circulation, which this will actually still occur in conditions like septic shock and fever. So this may still require some underlying cause in that. So this is where we still want to take our vitals pretty well. And when we talk about CRT again, it might be simple, but our CRT and our gum checking isn't just like, hey, how hydrated are they or not? Okay, they can tell me a lot with these tissues, without having to look directly fully inside those, like in the body cavity type tissues. So normal heart rate, again, be very mindful, whatever values you were taught or what you're sticking to, fine. Um, I'm not gonna hold you to these ones, but again, recognizing, hey, puppy and smaller breeds, 70 to 220, 70 to 180, average, medium breeds, 70 to 160, and giant, 60 to, actually, I'd even argue like 110. But again, what does your book tell you and what have you studied? And knowing kind of the mechanism, bigger dog, slower heart rate, smaller dog, higher heart rate. Um, so again, I'm not gonna be like, and I guarantee you the VTNE is not gonna have like 70 to 180 and then like 69 to 179 or like 60 to 1, 70. It's gonna just be like roughly where are these values falling into these broader areas for you, okay? So, with that, the other thing we want to talk about is with heart, okay, CPR. CPR is definitely a VTNE test-worthy question. Even though you might not have done it or nor wish to ever do it, you need to know some key components with that. So there's a couple different methods. So we have what's called the thoracic pump method for large animals. So this is where the thoracic pump method is more for more of these larger dogs. I would definitely study up on the different chest cavity classifications of dogs. Again, knowing some abnormal, like or sorry, excuse me, your comparisons is going to help you a lot in your studies, okay? What is keel chested, right? Is this going to be something that benefits this dog? So when we talk about this, this is where um, this vacuum effect is being created to help draw the blood back to the heart during each compression. And so CPR is something that should be able to be performed in all clinic capacity. When we talk about cardiac method, so this actually is more directly pressing the heart to move blood. So more of our smaller animals even deep or patients with deeper or those keeled chests, okay? And so these are where compressions are going to be directly over the heart's apex. So that's going to be around the fourth to sixth intercostal space. So spaces between the ribs, where the depth is going to be about one third to one half the chest at a rate of 100 to 120 compressions per minute. And then ensuring full chest recoil is being seen or done between each breath. So I would definitely highlight this need to know, should put away. Again, definitely CPR is a very optimal type question. How they ask you, I don't know. But there are different parts that can kind of come together when we talk about CPR. Okay. And so this is our optimal rate. And so this will help ensure effective circulation as well as oxygen during that code cycle. So this is our goal of full maintenance when we just talk about CPR as a surface level. Word to the wise, what does it stand for? Okay. Especially CCPR. Okay. I'm not giving you all the answers, so I'm gonna make you guys do a little work today. I can't know everything. Okay, how do we give air? Okay, so in small animal nursing, we talk about, hey, what's the best quality of air? Um, especially when we talk about maintaining that airway, we just said that is an important uh, component. And so a lot of things we do have some type of amu bag. So if this patient isn't under anesthesia, which 90% of the CPR codes do happen like this, where they're not under an anesthesia procedure. And so this is where that amu bag is helping to deliver positive pressure ventilations who are not breathing. And so when not connected to any type of anesthetic machine, it actually provides about 21% of oxygen. So making it more effective option for providing necessary oxygen during emergencies. We start to lose that quality in terms of like how are we giving that oxygen source and ventilating the patient. So a lot of times people will be doing this, and you'll hear the MU bag make its funky like bagpipe noise. But it's not ideal to put patient intubate and put it on the anesthesia machine. Yes, we have oxygen capabilities, but risks of gas exposure, and we don't know the quality, where this patient is at. At home, mouth to snout. Okay. This can be tricky because, again, owners thinking they know, but this method provides about 16% of oxygen, which is actually less effective and can be really limiting. It's all about the seal and capability. And of course, like it's not the effort coming from the owner. Whereas when we have the AMU bag, um that pressure is able to be substantially what's the word very gosh, words are hard. unified in pressure, right? Because when it's someone who's doing their breaths, and as we know in CPR, animal or people, it's easily to get tired. Okay. So, other essential parts of equipment. So again, touching base on the crash cart, what should be in there? What are some key things to be doing during the CPR code? So we always want to get pulse ox for oxygen saturation, not like priority, but it can be helpful. So once a patient is intubated, we can actually hook them up to pulse ox that way and get a lot of information there. Definitely ECG monitoring, and getting an idea of where that electrical activity is. Also, that ETCO2. Yes, this patient isn't breathing on their own, but we need to make sure whoever is doing the ambu bag is hitting that baseline goal to make sure a patient is getting proper oxygen. Also, Doppler, very pro Doppler. However, if blood pressure is below 60, it's going to be quite significantly challenging to get a Doppler sound at all. We also want to actually watch for ocular fluid overload because when we talk about signs of hydration and overhydration, because what's happening in during the CPR code, these patients are being fluid bolused, so lots of fluids at one time. Okay, this is definitely a VT&E question. There is a little acronym. People say naval, but I just say NAVLE, just because there's also a test called the NAVLE, and I don't like the word naval. It's just like the word moist to me. Okay. So there are key drugs you need to know that are related to CPR specifically. And so actually while that's happening, we can actually give a lot of these drugs down the trach tube. So drugs can be given intratracheal in the intratracheal route. And so this can definitely help. So this we have to keep in mind that some drug doses change given this route. Some don't, just kind of depends. But we want to make sure we do adhere to the proper dosing and technique to get the optimal absorption for drugs and, making sure we're kickstarting everything back up. I'm trying to remember. Um, CPR percentages are not quite like they are in human. I do know that. It's quite significantly less. I hate putting a number on it, but I thought at one point that there was anything from like a 5 to 10% chance, and that's pretty high with 10% chance of a patient coming back, depending on like how did this code kind of go about. So with that, like I said, Navali, naval, whatever. We have those drugs. So atropine, anticholinergic. This should sound familiar. So this actually helps increase heart rate and blood pressure. So this is when patients are completely tanked. We can do this, especially if we catch it, even in general. Okay, so dogs that are bradycardic. Excuse me. And so this drug is actually can be calculated in a quarter, half, and full dose, depending on your clinic. Some people have it in a quarter, half, three-quarter, and full, all based by dog's weight. Okay. So atropine. Remember, we also can have glyco, but I probably want to be dealing with atropine a lot more in this situation. So if you don't remember the difference between atropine and glyco, I'm gonna make you look that up. Epinephrine, okay? So this is uh definitely for a really, really low, if not absent heart rate, okay? So epi is also adrenaline, okay? So very, very helpful in any type of cardiac um emergency, but old school medicine, I think they still kind of do it, but epi can also help with allergic reactions to patients. So big thing is it does simulate the heart. Okay, so this increases the heart rate and blood flow. There are drugs that also affect cardiac output, which we can talk more about when we do some more pharmacology. But the usual dose for epi is 0.01 mg per kg. Okay. This can be given IM for emergency purposes, so keep that in mind. Naloxone. Okay. The only opioid antagonist. Okay. This reverses any opioid overdose, or even if this patient is under anesthesia and we're not liking our vital signs, we can give them some form of naloxone to reverse that. Okay. It can rapidly actually restore a patient's respiratory efforts pretty quickly. But when we talk about dosing, again, I don't think the VT is going to necessarily ask you what is the dose for naloxone, um, because the clinics I've worked at, we just do the point 0.1. Others can go to they do point 0.4 megs. So it just kind of depends and just repeating. But again, you need to understand that naloxone is an opioid antagonist, okay? It's waking everything up. It's canceling out the sleepy effects of the drugs, if you will. All right. So blood pH, and it's important. So we do talk about what's a blood lactate, okay? That's giving us an idea of lifetime of oxygen quality levels in the patient, right? Because what we talked about with blood. So you all kind of remember from elementary, junior high, or whenever, the, the pH scale and what's in the middle. And so for our dogs, we usually want a pH of 7.35 to 7.45. And so this is really important because this is going to help determine metabolic or respiratory issues and determining treatments. So this can tell me if a patient is acidotic or alkaline. Okay, so where do they fall on that acid scale? So 7 is not the safe number you would choose and what is normal when we talk about blood pH. So this is something, if you're in an emergency, you probably come very familiar. Never worked in emergency, came across emergency situations. Um, so key thing to understand what these numbers can mean and where we go from there. So, other things we talk about advanced drugs in any type of emergency situation. We do have something sodium bicarbonate. So, this is for severe acidosis. So, this is correct basically when the blood pH drops below 7. And so, this will help basically neutralize any excess acid that's in the blood to bring everything back up to normal pH levels. Help basically improving these metabolic functions in the blood. But if we tank again, we got to figure out what's causing this severe acidosis and what's kind of happening there. But knowing sodium bicarb is what's going to help with low blood pH. Other drugs, I even, okay, oh my God, you guys, I know how to say this. Amiodarone, oh my gosh, this is embarrassing. But it does help with VTAC. So it's my favorite drug, and I can't say it, but it's antiarrhythmic. Okay, so this is going to help with all those guys who are in VTAC. So on the flip side, just for your Gee Whiz collection, before I bust out this drug, amiodarone, guys, I'm gonna like wake up in the middle of the night saying this. God. Anyway, told you guys these things are very raw. And I'm not recording because I'm not re-recording because I'm already halfway done. The other thing that can help actually with VTAC, if anyone didn't know, is lidocaine. So actually, we would do a lot of lidocaine first, but if this was an anesthetic situation, I'd bust this bad boy out. So this would help me a lot with VTAC or VFib. Okay, so this helps stabilize everything. And so if we are dealing with cardiac resuscitation, um, basically cardiac arrest situations, we can bust this out. So this is definitely in your crash cart. But to be honest, we always just would try lidocaine first to break the VTAC. But we were also seeing some other arrhythmic problems. So big one here for VTAC. The other one we like to talk about is calcium gluconate. So this is a drug we can actually deal with when we see patients who are hypocalcemia. And so this is like in cats and dogs who going through eclampsia. And so this just helps provide additional calcium needs in different types for various physiological functions, okay? Such as muscle contraction, nerve transmission, because we still need to provide nutrients on that type of cellular level. Um, Excuse me. So this is something that we can see as well in terms of stabilizing patients, emergency settings, but also if we have a patient that we are concerned going through hypocalcemia, we can definitely do this. All right, level of consciousness or LOC. So again, this is neuro in a sense. So is this patient basically bright eye, um, bright and alert, responsive? Um, C mean engaging in some form, kind of taking in consideration. Of course, we talk a lot about fear-free. Is this patient depressed? Are they depressed from treatment? Are they on drugs? Are they drowsy? Are they semi-responsive? What's kind of going on? Are they kind of watching the environment or checked out, essentially? But depressed is still showing some um presence, but it's just a little bit reduced, and they seem a little more drowsy and just kind of like not fully engaging, but a titch potential. Quiet, so this is where they're just observing the environment, may or may not respond to any type of verbal stimuli, may need a little additional prompts. We might need to like amp up the energy for any type of response. Of course, then we have delirium or dementia type behaviors, where patients seem confused, their head pressing, seem lost, basically some form of cognitive impairment. And then, of course, comatose, so these patients are completely unresponsive, unaware of any type of reaction, and they do not respond to any verbal or physical stimuli, and may need additional assessment. So big one there. Still part of, the neurological function, okay? And Rotarun. See, guys, I'm gonna be saying this all night. I swear. I told you these are just so raw. I just came back from work, so just vibing. Um, And I had coffee really late. I'm sorry. You all know how I get. Anyway, so I'm not going deep into the lab values per se, but giving you a baseline. So what is PCV, right? Packed cell volume. So this is where we're able to kind of see how hydrated or dehydrated our patient is. And so, hey, maybe some key features going back to, is this serum? Is this plasma? What's that little thing between the serum and the packed cells? Some things that are familiar. How do we make it, right? Um, Essentially, and so then in the interpretation, so are we seeing hemolysis or icterus? Is it really lipemic, and what does that mean? So again, depending on your book and what you wrote down, these are just some typical values we talk about when we talk about total protein. So dogs and cats about 5.4 to 7.5. For dogs and cats, 6 to 7.9. When we talk about total protein. And so now we got to interpret what's that PCV, or a lot of people use PCV and hematocrit interchangeably. So are we seeing that at a low percent? And then are we seeing the total solids or total protein low or high? What does that mean? So if I have both that are low, I have blood loss happening somewhere. If I have a low PCV but a high total solids, the patient is more anemic than we actually think, and the body is just kind of, starting to trend more in that south direction. If I have a patient that has a normal PCV but a low total solids, this can be pretty much still blood loss, but hypoproteinemia. We also have abilities to know, like, hey, if these are low, we can also see dehydration. Um, and so we got to correct that. So that's how we're kind of interpreting, if one is higher than the other, or if they're both low, both high. Where do we kind of go down that differential list? Okay. So BUN, blood urea nitrogen, you probably should really know this. Again, if there's going to be some key blood values to know, they're ones related to this presentation today. So BUN, live, breathe, die, that it goes to kidney, okay? It is a kidney value. And so we already kind of talked about that we don't get to see kidney values compromised till they're about 75% gone. And so we basically have to keep that in mind when we are doing our labs, because if the patient seems high normal, it might be a little deterrent. So when we talk about BUN, so that's measuring the amount of nitrogen in the blood. And so it comes from urea. And so that's where we reflect that kidney function and that hydration status. Kidney disease is a big deal, right? They get hit hard by drugs. And so this is where I told you guys when they invented the SDMA. It's a better concentration to see where those kidney values truly are. So they are stage 1 through 4, one being early, four being severe. These are just some semi-relatable values. Again, some doctors might flux these due to that patient's norm, like if this patient is on drugs or not. So anything less than 1.4 for creatinine with BUN is good to do. And then, of course, less than 14. For the SDMA. So the SDMA, remember, it's more concentrated to ensure does this patient have kidney disease or not? And so this is where we can start to see some signs. So on the high end, in stage four, with chronic kidney disease, these guys definitely have a creatinine of 5 or greater to be stage four, and their STMA is above 45. Big. So I definitely had some patients with high BUN creatinine SDMA levels for sure. So knowing what that looks like, so excessive drinking and urination. We can also see a lot of lethargy, not eating, anorexia, frequent vomiting and distress, failure to thrive, essentially. My soapbox, you better know what BUN stands for and what organ it goes to, because that's a big deal. Creatinine. So this is B1's best friend. And so this is where you guys need to know the term azotemic. Okay, B1 creatinine equal azotemia. Yes or no, essentially. Where are these values? So creatinine is a waste product from the muscle metabolism that's filtered out by the kidneys themselves. Remember, they have to kind of take everything and filter and disperse. Okay, how do we eliminate? And so, if the creatinine levels are actually elevated, we are seeing more kidney impairment. Okay. So, cats less than 1.6 and 1.4 for dogs. We do not classify them as azotemic. However, as we kind of progress up the scale, we can see patients with normal creatinine levels and higher BUN levels. So, when we talk about azotemia as a whole, azotemia is some form of kidney disease, as in the creatinine and BUN levels are somewhere between, mild to severe. Okay. Whenever I see labs, I don't need to see red to know, like, oh, shnikes. So I definitely seen creatinines up to 5.5 and 6. I've seen BUN levels. I think the highest one at one point I saw was close to 400, and we had to dilute that at one point. So yeah, soapbox, BUN and creatinine is how we categorize azotemia, which is referencing chronic kidney disease. You guys better know that. I'll be so mad. I've taught that so much. And every time I see that miss on that final for small animal nursing or lab procedures, I know I taught you guys that. So, glucose levels, okay? So this is kind of giving me an idea of where that patient's metabolic state is. So this is helping me kind of get an idea of conditions like diabetes or even hypoglycemia. Okay. So depending on if they're on any type of insulin, hint, not all insulins are created equal. Did they eat or not eat and things like that. So we can take a look at good glucose levels, and um, get an idea of like 80 to 120 for cats is pretty good. Anything above 200, we're definitely concerned here. Okay. So a lot of you guys might have come across glucose curves. I definitely would like to do more systemic testing to go over some diseases with you guys so you understand that, but not today. Other really important values that get forgotten and make me really sad is potassium. So renal K plus, this sits in all your guys' pharmacies. It's not I'm trying to remember what that green one was. It's the same consistency though. But when we talk about potassium, this is really crucial because this really helps with cellular function, especially with cardiac production and muscular activity within the cardiac muscles. And so we got to understand, like if we see low values or low potassium, meaning hypokalemia, so this is resulting from kidney loss or any type of GI fluid loss. So this is really important when we do our blood work. We got to make sure we cover all of our bases. So chemistry panels are huge. We also need to understand that high potassium levels are hyperkalemia. We'll see this with patients who have severe kidney failure because they have all this buildup of potassium with nowhere to go. And so we'll start to see patients who are depressed and weak and start to throw arrhythmias, okay? So anything pretty much above 6.5 is considered hyperkalemia. We would argue about 5.5, but again, my personal opinions are not that of the board. So kind of reference your book a little bit if needed. But we supplement that with renal K. So we do talk about, hey, the heart helps with pumping, and we have our cardiac system and dealing with getting blood flow. So potassium levels are a very, very key component of that. So electrolytes again. So this you can do potassium by itself, but again, it can be categorized with the electrolyte panel. But the electrolytes, again, help with maintaining fluid balance. So we need that for outside of just cellular function, but muscles and nerve fibers, okay? So this is why we do always want to do a chemistry panel. And so remembering that that's going to be working off of serum. Okay, so we like to spin that down and kind of transfer that process, that byproduct to kind of measure and see proper hydration as well as proper blood pH in a patient and any other potential values that might be spiked. So blood work tells us a lot. So these are some really big key components on blood values in the whole in terms of like how do we just interpret those and what do we look at? Okay. So again, I will go in deeper down the line. Other issues we can run into, so we can see abdominal issues within critical care as well as in the GP setting. And so we can see things like abdominal retching. So this is where we talk about non-productive retching. So this is where there's a lot of abdominal distress. And so this is where an animal will actually try to vomit, but nothing happens. And then we start to run into potentials of patients who have ascites present on their abdomen. And where can this be coming from? Whether it's right heart failure, valley fever, or any other additional situation running into. Other abdominal issues we do see within the abdominal cavity, of course, is GDV. We also see patients who are struggling with to get comfortable, so potential foreign bodies and things like that. We did talk about VTach, so tachycardia itself. So again, this is that increased heart rate, and so patients don't have to have heart disease to go through a heart situation. Okay, so we're having some form of electrical conduction here, and so when we talk about shock, there are different kinds. But this is just kind of some key components that what we can see are attributing from shock. So again, with abdominal issues and then tachycardia as well. And so this is where this is telling me there's something going on in the body that the body can't maintain blood flow quite appropriately. And so what's happening is the body's panicking, and then we're starting to not get enough blood pumped out to the body. And so we're not having enough time for that heart chamber to fill up. Okay. So really important here that you guys understand what that looks like, not just for the VTE, but like, um, if you can develop a sense of identification of just at least knowing that's not normal and compared to a normal ECG or EKG, then that's a strong start. Tachycardia is not always, um, also due to any type of structural heart disease. Okay, that can be the body's response to shock itself. Other shock signs we can see, so we did talk about pale, muddy gums, poor perfusion there. We also can see that inability of proper adequate oxygen to the tissues. We can see patients who are collapsing, vomiting or diarrhea are a big deal there because then we can start to see trends with some type of potential internal bleeding. Also, we can see weakness and disorientation in patients who are very, very sick, and even just cancer as a whole being that final differential. So, other things when we talk about things that how do we manage and how do we triage and what else we can see, vomiting and diarrhea are definitely a big part there, okay? Water is essential for life. And so if I'm having what we call ongoing losses with vomiting or diarrhea, we got to manage that. So how do we do that? We got to restore fluid. So we'll do a lot of fluid therapy to help regain patients' ability to have electrolyte status by correcting that dehydration. So this will kind of determine how severe those patients are and what's kind of going on with that. So antiemetics, what is that? Okay, so that's actually types of medications to help control vomiting. So we want to make sure we introduce antiemetics in patients who are struggling there. So we do see a lot of ondansetron use or metoclopramide. We might just determine which one to use depending on what we're dealing with and diseases and affordability. But those classes can potentially help stop these ongoing losses we're seeing. Also, nutritional support. We got to remember to give them some form of nutrition. Yeah, patients can be NPO, but we might need to still correct that, making sure we get back to GI homeostasis. Okay. Um, so we talked about neurological issues and symptoms. So some things we can see with neurological diseases. So again, terminology, we can see patients who are ataxic, We can also see some limb dragging, abnormal gait, patients knuckling. We can see tremors and twitches, just depending on what brings them in and potential history there, or if this is new. A big thing that people forget can be related to neurological diseases is ocular signs. So we can see the nystagmus is a big one. So different types of eye movement uncontrollably. Also pupil abnormalities. So aniscoria and myitis with different types of pupil shape. We also can see rapid vision loss in patients. Basically, they have unmanaged kidney disease or yeah, unmanaged kidney disease and blood pressure, so they can actually detach their retinas. We also can see reduced menace response, so when they're not blinking. So those are some big parts too that aren't just attributing to ocular disease itself, but can be signs of neurological problems. We also talk a lot about loss of motor functions, so down in the front or back end, and this could be from potential blood clot issues, diseases, spinal cord injuries, and things like that. So this kind of got out of order, so I apologize. Um, Fluid therapy. So resuscitation and maintenance. So with dogs, the shock dose is a standard dose. So it's 90 mils per kg. And so if we're dealing with hypovolemic shock, this is something we can go ahead and introduce. So this is where we'll do rapid infusion based on that dog's weight. We also have a regular maintenance weight, so some people do 60 mils per kg per day as just standard maintenance rates. However, some can argue, depending on comfort. I've had doctors do 5 megs per kg per hour. So, but these two numbers do relate to specific treatment plans. So 60 mils per kg per day relating to maintenance, and 90 is a shock dose. So blood products are big, especially in the ER. But I worked at GP, we dealt with this. So we have different kinds of blood products to help with patients. So I'm not going to talk about blood typing and all that entails. Maybe another time. But when we talk about packed red blood cells, okay, so these are typically going to be actually administered at a dosage of a mil per kg for each 1% desired increase in PCV. Okay, the maximum we can operate with a packed red blood cell is going to be 20, or excuse me, is going to be 10 to 20 mils per kg over a 4 hour period. I actually just went to a CE, and the ER veterinarians did talk about transfusing. And so anything past 4 hours, that blood actually cannot be room temperature. So if you exceed 4 hours, dispose. Okay. We can do whole blood. So this is given actually at 2 mils per kg for each 1% desired in that increase in PCV. So we can do 5 to 10 mils per kg over again 4 hours. So this is really important when we talk about patients who are acute hemorrhage or severe anemia. With that. And so at this lecture, which was really unique, is a lot of them did talk about using certain types of filter systems as well as using IV pumps, but they actually said, hey, gravity is best. Which to me was like, okay, cool, but that means I'm gonna have to figure out how to count the drops to that. So pass. But just note they do also make pumps that help set that to go accordingly. Other type of blood products we can use is fresh frozen plasma. Okay, so this should be administered at 6 to 15 mils per kg for coagulopathy, and then 30 to 45 mils per kg for any albuminemia. Geez, spell that. And then the maximum administration rate is going to be 6 to 20 mils per kg over 4 to 6 hours. So that plasma is that byproduct. So we're not as worried as that 4 hour mark as the other type of blood products, if you will. I did a lot of this actually with neonatal care and equine, so really great stuff. Liquid gold. All right, home stretch, guys. So when we have to deal with patients who are hospitalized, we got to remember their weight, okay? I don't want to over jam patients who are recovering from not eating and vomiting diarrhea, but they still need to obviously have nutrition to sustain life. So what does that look like? Well, we got to talk about some key components when it comes to nutrition. So we do talk about protein. So proteins are good. And so this is protein use is helping repair any type of tissues, helps with enzymes enzyme synthesization and supporting entire immune function. So, when we talk about protein components, they're typically made up of amino acids, which are the building blocks to pretty much all of the body structure. So, protein, number one. We also do see a lot of carbohydrate sources, and so that's energy. So we can see this in grains and vegetables and fruits. While not essential, they are beneficial for overall digestive health. Now, I am not one for the pet food department situation. However, you will come to notice some doctors will be like, hey, I only want them to get a slurry of AD for, this morning. Because we have to look that all dog foods and slurries and cat foods are not created equal. Hence why, depending on what's going on with your patient, like a lot of parvo dogs would get the Royal Canin Recover, to make sure we're replacing what we're losing. Other benefits for diet is we have fats, okay? Uh, I will say that I did have something in relation to understanding fat and water soluble vitamins and which are which. But the fats provide, support and energy to the cell structure. So we have A, D, E, K, and so those are some big components we work with. Vitamins as well, very important. So immune system, bone health, overall vitality. We do see A, C, D, E, and K as well. Minerals, very important, bone development, nerve function, and metabolic processes in patients. And so some basically minerals that we would like to see present are going to be calcium, phosphorus, potassium, sodium, to help again maintain optimal life. So, a big thing there to understand. Again, I'm not the strong nutritional overall, but we have to talk about with patients. You guys should review your RER, resting energy requirements. The requirements for a puppy is going to be very different from an older dog. That's like, and it's easy to buy products that look cool. But your couch potato dog does not need the 70-30 blend, or what is it? It's not 70-30, sorry. Like the 30-10 blend of high protein from Petco, because they're not working enough to burn that off. So we're like, oh, hey, this has a really cool athletic dog on it, but the nutritional requirements are higher. So if I could give you any advice on where to go with that is understanding what RER is and going from there, and kind of researching that a little bit. I did not get a chance to go in depth with teaching it. But oftentimes what we come across in nursing as a whole is like, hey, we're dealing with patients who have nasogastric tubes, peg tubes. We got to be mindful of how to administer proper nutrition that way. So again, the board likes a lot of acronyms and things. So the AAFCO, that's that nice little company that is not basically funded in the sense of like FDA research. They are basically using real life animals to get their data, not a controlled situation. Like a lot of lab, setups with food trials and things like that. But the AAFCO guarantees a lot with ensuring that those diets with those stamps meet the proper nutritional standards of what's good. So your big three are Hills, Purina, and Royal Canin. So guys, thanks for hanging out with me. Sorry, this one was probably the most sporadic lecture. But some key things I always like to remind you guys, know your normals and your abnormals. This will really help with treatment steps, but also when you are sitting and facing whatever question, you can kind of figure out from there, what is the question asking? Okay, you can be like, you know what, I don't know the core of this question, but I can look at the answers and be like, I know what this is and that is, and kind of go from there. Like I said, this was part one, very superficial, okay? The next time, part two and three, I would like to kind of help assist you guys with talking about heart murmurs, ECGs, drugs for those two systems on how to combat that. Also some other things too, trying to tie in a little bit of lab procedures with like understanding that mechanism and pharmacology. Like I said, this was such a big topic itself with the nursing component, and it making up a big part of the test. So I promise I'll kind of keep pumping these out the best of my ability. They're very raw. They're just from my brain, to kind of also help you guys realize where do I need to go with my studying. Okay. Open that giant McKernan's book. I swear my back problems are from carrying all those books with me to the library every day. But I promise I will kind of build up on this and kind of go more in depth on some of these systems. But you guys need to know, basically our intakes and triaging. And, again, triage is not just for the vet ER areas. We triage in a GP setting and interpreting that information I'm getting. I've had patients again come for standard care that I start to my vitals and I go, no, this is about to go down really quick. So again, very part one. And so I intend to still again give you guys another part two and potential part three, kind of helping direct you guys on where to go on some of this material and understanding what it means. So yeah, thank you.